Good morning, everybody. Welcome to another edition of the AFR EMS case studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire Rescue. And today we're joined by Dr. Kimberly Pruitt, our Medical Director.
Hi, Chief.
Morning, Doc. And we're also joined by Lieutenant Jeff Garcia from Rescue 15.
Yes, sir.
Thank you for joining us today. I really appreciate you taking the time because this was a very interesting call that you went on for a 6 Delta, but it had some unique perspectives as far as patient history. So let's get right to it. So Rescue 15, Engine 15, you guys are dispatched to a single family residence for a 6 Delta.
Correct.
Kind of 6 Delta is pretty regular or common dispatch. What are your thoughts? What are you thinking through when you're on your way to a 6 Delta call?
Just whether the pulmonary issues that the patient actually has. Do they have COPD? Is it CHF? So on and so forth. When I saw muscular dystrophy on the AR notes, I wasn't thinking anything of it. I was thinking maybe some extremity, muscular dystrophy, generally what we normally see. So nothing out of the ordinary. I wasn't stressed out about the call. I arrive on scene, introduce myself to the EMS contact like I normally do. Hi, my name's Jeff Garcia. I'm a paramedic. I work for AFR. How can I help you? Her demeanor and her mannerisms let me believe that this is a routine call. She's just calling to make sure that he's okay and just wants some help. She states that she's the manager of the group home. She's like, normally I give him an albuterol treatment, but it hasn't worked. So our guys are walking in. We walk into the room, and I immediately feel the stress levels starting to rise. And that's just because of the way that the patient is presenting. He's almost presenting like he's like a child, like flaccid, guppy breathing. He can't really, there's no accessory muscle use whatsoever. He's not really getting a good deep breath. So I immediately, I see what needs to be addressed, and I tell the guys, I'm like, hey, we need lung sounds, CO2, and or an end tidal, and we need a room air sat. After that, we're going to get a full set of vital signs with the 12 lead. So I focus my attention on her so the guys can work and kind of like keep her calm, because she's starting to realize like this is a critical call. He's not presenting the way that she normally sees him, and this could be, he's borderline in between respiratory distress and respiratory failure, and we're watching him kind of like hang out in between the two. So we weren't able to get an end tidal. Room air sat is 65, and he has wet lung sounds. So I'm like, all right, we need to go straight to a CPAP. And so I call it out, hey guys, let's go straight to a CPAP. In the meantime, let's get him on a non-rebreather until that CPAP's ready. So I'm asking the manager, like, hey, was he sick recently? Anything? She's like, yeah, he's been sick for the past 3 weeks. So now I'm like, does he have pneumonia? Like, what does he have? Like, I'm not sure what he has, but we need to definitely help him. So we put the CPAP on him because the non-rebreather has not even touched him. So we put the CPAP on him, and he's just not really able to get any sort of like pull. Like, there's no like vacuum. There's no breaking of any seal. Like, we're trying to coach him through this, and I think we tried for about maybe a minute, and I'm like, okay, you could tell like everyone's kind of like getting antsy in the room, and so you could hear a pin drop, and before I can like say what my next treatment is, my driver's like, hey, let's go. I was like, yeah, let's go to a BVM right away. So we go to a BVM, and they're like, hey, do you still want the albuterol treatment? I was like, yeah, let's do a dual neb, but let's make sure that the BVM's working first. So obviously we get the BVM working, get some decks on board, and he's not presenting any different, which is weird because his O2 saturation's coming up, but he still looks like he's getting tired now. I'm like, okay, we need to help him out as best as we can, stay aggressive before this goes any further. He starts to deteriorate to where he could code. I'm thinking we need to leave. I don't know where 5-5 is, and I don't care where they are. I just need to stabilize him enough so that we can leave. We get his O2 sats up, and he's like I said, he's not really presenting any differently. He's still in distress, but his O2 sats are up, and I'm happy with that. His 12 lead was unremarkable. He's doing vitally, he's doing better, but he's sick. He needs definitive care. So AAS arrives. I'm like, oh, I didn't even know you guys were here. So we transferred of care to AAS, and they got him transported to the hospital.
And the group home dynamic is always interesting. We do have a fair share of group homes within the city limits that we respond to regularly, and I think we have a whole spectrum of capabilities and levels of care at some of these facilities. So that's already kind of a challenge when we walk into those calls. This gentleman specifically, still young, 38-year-old male, and you said you'd found him, he was wheelchair bound.
Correct.
Talk to us about a little bit of the history that you were able to elicit from either him or from the caretaker.
The caretaker was just saying that he had, he did have a pacemaker. He did have muscular dystrophy. He was recently sick, hospitalized, so on and so forth. But he was playing he was playing Call of Duty right before this happened. So I was like, okay, he has neuromuscular movement is fine. I'm just not sure how he went from, hey, I'm having trouble breathing, to now this is an acute patient. This is a high acuity call in a matter of seconds, maybe even minutes.
Pretty rapid deterioration, and probably likely due to the muscular dystrophy diagnosis primarily, right? Along with being sick. Doc, it's not a condition that we typically run on. We know a little bit about it, but talk to us about muscular dystrophy, what that means, and what can we expect when we encounter a patient like that.
Yeah, this is a really interesting call from a pathophysiology standpoint. With muscular dystrophy, it is more common in males, and they do have a decreased life expectancy typically. So this is actually on the older end of the spectrum for most muscular dystrophy patients. And it's basically just a disease process. It's still not really well understood, but basically muscles degrade and cease to work over time. And in this particular case, my suspicion would be, it sounds like he's already got a pacemaker, so we know he probably has some cardiac involvement. The heart's a muscle and seems to be failing a little bit for him. And then I suspect with him just recently being hospitalized and getting worse over the last couple of weeks that he had probably been hypoxic for a little while and just able to compensate with his SATs in the high 70s and 80s. And then once you start to dip just a little bit lower is when it truly got to be severe respiratory distress. But the diaphragm and all those intercostal muscles, I don't think we think about it that often, but those are very important muscles for respiratory effort and for breathing, and their muscles as well. And so as they start to degrade in these disease processes, whether it's muscular dystrophy or ALS, it's very difficult to take that deep breath and the negative pressure that you mentioned. I think that's what's happening here. And so the fact that you recognize that he needed positive pressure and he needed you to force that air in for him was, I think, a huge step here, because you're right. You're describing someone who is peri-arrest without your help.
Yeah, that was key, and I think you zeroing in on the respiratory issue, like right off the bat, just your spidey sense said that this patient is sick. Like, we really need to focus on these specific vitals, and before we get anything else, we're going to start treating his respiratory issues, first with the CPAP, or first with the non-rebreather, then with a CPAP, and then having to go to BVM. You did talk about an increase in end-tidal and kind of looking at, in O2 sats, and looking at the chart. It looks like he started out at 65% room air, which you stated, and we got up to the 80 after the CPAP, and then with the BVM, we were up to 96. Is that accurate?
Yes, yeah. I thought that was a fantastic job on the guys. I mean, as a leader, you're continuously evaluating your personnel, your subordinates. But where I like to really evaluate my guys is what happens when things go wrong. What happens when you think you have a plan, you set up your plan, and it just doesn't work. That shows me, they're growing, they're thinking ahead of things, they're in the game with me. We're all in this together. And so for Angelo to, us complete the sentence together, like we're on the same page, I was like, this is fantastic. And I told him that after we got done with the call and we did the tailboard, they were like, man, that was kind of iffy. I was like, yeah, I know it was a little stressful, but the more we maintain our composure and we can think this thing through, the better off we're going to be,
And we talked about the Duo-Neb from the pharmacology side. Any other medications that you guys administered?
Just the dexamethasone.
We did dex as well, okay.
Right, and then, we're obviously for a COPD patient, maybe even somebody with asthma, you're thinking magnesium. Magnesium's not going to help this patient at all, So this drug is just we're not even going to talk about it,
And got a 12 lead. We said that was unremarkable, kind of a sinus tack, but looking out for those cardiac problems as well, because he did have that history. So that was a fantastic job. Other than what we did on scene, which ultimately saved this gentleman's life and carried us over to get him his definitive care, what is definitive treatment for a patient like this once he gets to your hospital?
So this is a really difficult disease, and this patient, I think, had probably reached the point in his disease where he made it clear that he was going to need persistent respiratory support. So there may have been an underlying cause, like you mentioned, maybe a pneumonia or something that would be treatable.
Yeah.
But my suspicion is his disease had progressed to the point where he's going to need continuous ventilatory assistance, and I wouldn't be surprised. I'm sure they intubated him when you got to the hospital, and then it'll start discussions about probably long-term ventilation with a tracheostomy and a ventilator, and then you get into goals of care because this is really near to the end stage of his disease, likely.
That's tough. But in terms of like the emergent situation, you guys did a fantastic job. It was like, I wouldn't want to say textbook because you guys went above and beyond and killed it and recognized exactly what needed to be done and acted decisively. I like the fact that you brought up the tailboard because I don't think that happens enough. I think like on our structure fires, we take time to get with the leadership, get with BCs to talk about what went well on this call, what could have done better. But doing that on the EMS calls, I think, is a testament to your leadership to be able to ensure that everybody's on the same page. So I thought that was fantastic as well. In hindsight, I can't find any. So in hindsight, if you were to have this call again, is there anything that you would do differently, do the same, or change?
I think I would have done everything the same. I just think the crew seeing the progression of the call, I think that they'll be able to anticipate a little bit better to where, and that's just, we haven't seen this call before. You know, normally it's a COPD patient, quick, easy fix, asthma, so on and so forth. But for muscular dystrophy, they're like, why isn't this working? And that's something that we had to talk about afterwards, where I explained to them, you know, if you imagine filling up your sink with soap and water, the suds are on top. You need to blow some forceful air to at least see the surface of the water. He didn't have anything for us to even work with. So we need to get that. We need to get the medicine to where it can be, but we also want to push some of that fluid out to where we can have more surface area for that dual neb treatment to come in. And they're like, man, that makes perfect sense, you know.
And you made mention of it, but I want to touch on it one more time because I think historically what happens is we see this patient, we immediately know he needs CPAP. We give him CPAP. We went from 65 to 80, so we're like, okay, we're okay enough right now. And a lot of folks might have just been comfortable with that. Talk to us about your decision point on when you said even this CPAP, even with the increase, it's not working.
Just his presentation. His presentation wasn't comfortable enough for me to continue that treatment. And then, like I said, you could hear a pin drop in the room because everyone kind of like, is this going to work or not? And it's like, no, we're just stay aggressive, guys. Just stay on the task, mission oriented. We'll take care of it, you know. And everything just happened smoothly.
It's perfect.
Just keeping calm, everyone staying calm. Let's just work through it, think through it, talk. Let's talk. I tell the guys a lot, like if in those situations, I expect you to be talking, you know. Little things, if you notice something different, say it out, you know, speak. I'd rather you say something than get done with the call and say, hey, you know what, maybe I should have said something. Like, no, not with me. Let's say something.
Right.
Yeah.
Agreed.
Yeah.
Doc?
I had a question about the patient. Was he alert enough to have that look in his eyes where he's like, have that look like, please help me?
Yes. Yeah. So he's telling me like, I can't breathe. I can't.
Yeah.
And I'm like, hey, buddy, we just need one good breath for the CPAP thing to work and just a minimal amount of effort. You'll notice, like, okay, if that's what I need to do to get the next breath in, the CPAP will work. And he wasn't able to do any of that.
But you were able to, like, talk him through what you were doing,
Correct.
and he could tell you were trying. How did the wheelchair add to any complexities with the call, like with moving him or with bagging him, or was it something that was easy to work around?
No, we worked around it. We were able to, we were really aggressive with the airway. So we had, you know, one guy making sure that we had a really good seal, one guy making sure that he's bagging, and another guy just holding, you know, head tilt, chin lift if we needed it. We totally focused on just making sure that he was getting the best airway care that we can give him. Yeah. Because I was like, okay, supraglottic airways, advanced, you know, I don't even want to go that route.
Right.
Let's not even get there. Let's fix it now.
Sounds great.
Yeah.
Tackled ABC's airway first, and then real aggressive with the airway. I love it.
Yeah.
Nailed it. Fantastic job, dude. I really appreciate you coming to talk to this because this is a unique call, and like when you have that palpable, like everyone's watching what's
Yeah.
happening in that. Everyone's getting collectively a little bit nervous, but I think you hit the nail on the head, keeping that collective calm, like you as the leader in that room. They're watching you, right? They're watching every move that you make. Every time you look like you're going to panic, they're going to panic. And I think your presence, ex-military, yeah?
Yes,
Yes,
sir.
and I think that's where that comes from too. So I truly appreciate your leadership on this call and then taking the time to come and talk to us, because I think there's a lot of new medics and even seasoned medics who have not seen this, and I think this will be helpful for them moving forward to take those
absolutely.
same steps. Cool. Well, fantastic job. I appreciate you coming to talk about it. That's it for today's session. If anybody has an interesting case they want to bring, we have a SharePoint tab where you can make the submission, or you can reach out to your 7-8 or anybody in the EMS division and come talk about it. Until next time, we'll see you. Thanks.